Hello everyone, welcome back to the channel, and you're watching the episode 3 of High Yield Ortho-Rheuma AMC series that is specifically made for only the high yield information about the subject, about the topics that are frequently being asked, and including the information from recalls. So in this one, we'll be covering bone tumors, Paget's disease, cervical trauma, in which Canadian C-spine rules and the nexus criteria. Then we have epicondylitis. Then we have Morton's neuroma and Coley's, Smith and scaphoid fractures. Along with that, the cast presentations and what is the treatment for all of these. Starting off with bone tumors, although this topic is very huge, but I want you to only focus on the age, the location, the systemic symptoms and the radiographic clues that are being present in the question. For benign tumors, I am only focusing on these four, but if you want to look at the others, you can check it out. First one is osteochondroma, the second is osteoid osteoma, the third one is osteoblastoma, and the fourth one is osteoclastoma, also known as giant cell tumor. So I'll give you only the important information that you need to see in the question, and that's it for the diagnosis of these cancers. So first is osteochondroma. The only thing you need to remember is there would be a lateral bony projection with a cartilaginous cap. That would be very significantly visible in X-rays. Second is osteoid osteoma. It has very similar presentation to osteoblastoma. There would be nocturnal bone pain with prostaglandin involvement, so the pain could be relieved by NSAIDs. The important thing that differentiates between osteoid osteoma and osteoblastoma are two factors. One is the nidus size of osteoid osteoma would be less than 2 cm, and in osteoblastoma it would be more than 2 cm, and it is not relieved by NSAID. So the pain is not relieved by NSAID. These two factors we need to remember. The last is giant cell tumor. So it is also known as osteoclastoma, and on X-ray you'll be able to see soap bubble like lesion very prominently visible on X-rays. That's it. Next is malignant tumors. So I have taken two of the most important malignant tumors with radiological signs that are important. So first is osteosarcoma and the other one is Ewing sarcoma. So I will only tell you the most important things that you need to see in the question stem. So starting off with osteosarcoma, you'll be able to see a Codman's triangle. Then we have sunburst appearance. And the last one is there would be a painful enlarging mass. And the age plays an important role in osteosarcoma. It is commonly seen in less than 20 years of age. This is for osteosarcoma. And then Ewing sarcoma, there are anaplastic small blue cells. There would be onion skin like presentation. It is common in children and fever could be a presenting complaint. And this child, it is a very common picture. It is present on the jaw area. That's it. Next is Paget's disease of bone. So basically it is a chronic focal disorder with abnormal bone remodeling and with excessive bone resorption followed by disorganized bone formation. This is the basic pathophysiology for it. Now, if you are suspecting Paget's disease, then ALP levels would be skyrocketing. There would be very high levels. Along with that, calcium and phosphate levels would be normal. So this is diagnostic for Paget's disease. Along with that, on X-ray, you'll be able to see mixed lytic and sclerotic lesions. Along with that, thickened bone cortex would be there and bone expansion would also be seen. While doing bone scans, you will be able to see multiple hotspots. That signifies that there is an increased uptake at active sites. Now this X-ray is very much important. This signifies cotton wool appearance that is being seen in Paget's disease, and there would be frontal bossing. Now for the diagnosis, the investigations, keeping in mind that we have taken ALP levels, X-ray, bone scan, and for the confirmed diagnosis we will do bone scintigraphy. This is for the diagnostic part. Then we have for the treatment, we are using bisphosphonates as the initial treatment. Zoledronic acid is preferred over alendronates and other drugs. Then for the pain management, we'll start off with simple painkillers, that is paracetamol, and then we'll move to NSAIDs. Calcium and vitamin D supplements are suggestive, and we have to monitor ALP levels so as to see if the treatment is working or not. That's it for Paget's disease. Nothing else you need to know. Next is cervical trauma, and I'm telling you Canadian C-spine rule and nexus criteria are one of the high yield topics. So starting off with Canadian C-spine rule, there are three factors you need to consider. First block is high risk patients, the second one is low risk patients, and the third one is if the patient is able to actively rotate his neck laterally with a 45-degree angle or not. So if any of them is positive, then we have to do C-spine immobilization along with. So next is nexus criteria. So this is a mnemonic. I'll tell you what each letter stands for. So first is N for neurodeficit. The second one is E is ethanol ingestion or alcohol intoxication. The third is X, that is extreme distracting injury. U is the patient is unable to provide you history, signifies altered mental status. And then S is spinal tenderness on the midline. This is the nexus criteria. Now if any of these is positive, then hands down we'll have to do some sort of radiological intervention. Either it could be X-ray or it could be CT. It depends on the patient status. This is important. You will be able to see these things in the question stem and all the information that is being present in the Canadian C-spine also. So answer accordingly. Next is epicondylitis. So there are two types. First is lateral epicondylitis. It is also known as tennis elbow, and mainly it affects the extensor muscles of the arm. And the pathophysiology for it is there is an eccentric overload at the origin of common extensor tendon, and the only thing that you need to remember is whenever you are extending your arm and when trying to flex the wrist or extends the wrist, you will be able to feel the pain on the extension of the wrist. That's when there is problem with lateral epicondyle, and there is basically an inflammation process that is going on for lateral epicondylitis. Then the patient will present with pain with resisted wrist extension, and there would be decrease in grip strength of the patient. Next is there would be point tenderness at the tendon insertion point, and on imaging it is usually normal. So it is a clinical diagnosis. So there is no need for you to dig deep in the diagnostic investigations. Now coming to the treatment for lateral epicondylitis. So there are non-operative treatments, that is conservative treatment, and then we have surgical treatment, that is definitive treatment. So for non-operative, there are conservative things that we can do. So activity modification is one of the things. Next is the patient can have ice packs. For pain, the patient can have NSAIDs, and patient can undergo physiotherapy. Along with that, bracing can be done. If the pain is not relieved with NSAIDs, then steroid injections can be used. But the definitive treatment for lateral epicondylitis or medial epicondylitis is release and debridement of the particular tendon and the surgery for it. And the other one is medial epicondylitis. It is also known as golfer's elbow, and mainly the flexors are involved in medial. So the site for pain would be on the medial epicondyle, where there is flexor pronator mass is present. Now, similar to that of lateral epicondylitis, I want you to straighten up your hand, then try to flex your wrist. As soon as you'll flex the wrist, you'll be able to feel pressure on the medial aspect of the forearm, and that's when you know that medial epicondyle is associated with flexors, and that's what you're going to focus on in question stem. Then for the clinical presentation, same, it will be worse on gripping and on the wrist flexion. That's it. Now considering the treatment for it, so treatment is very much similar to that what was for lateral epicondylitis, and the same thing we're going to do for the treatment of medial epicondylitis also. So next one is Morton's neuroma. It is also known as interdigital neuroma, and the basic pathophysiology is there is a painful entrapment of the neuropathy. It is commonly seen in common plantar digital nerve. The most common site for Morton neuroma is between third and fourth metatarsal heads. Now the clinical presentation. So patient will describe the sensation as walking on pebbles. It worsens on weight bearing. It is more common in women's. Then the pain would be of sharp burning forefoot pain. Then it can radiate to the toes also, especially to the third and fourth toe. Also seen when the patient is trying tight shoes or wearing tight shoes. Now paresthesias can also be seen. So basically a tingling sensation would be there in a plantar aspect of the foot. Now the most common sign associated with Morton neuroma, that is the Mulder sign. It is basically a clicking or snapping when squeezing the forefoot, and the pain would be there. So this is diagnostic for Morton's neuroma. You'll be able to see the site you already know, and then we'll discuss the treatment for Morton neuroma. It is similar, that initially would be conservative treatment, and if the patient is not able to feel relief after that, then we can opt for more invasive things, and then we can opt for surgery. So non-operative would be using a wide shoe box with a firm sole, or you can use steroids or local anesthetic injections into the neuroma. And the third line, that is the surgical excision if the pain is persistent or the conservative or injections have failed. That's it for the treatment. Next is the fractures. So we have three fractures. One is Colles fracture, the second one is Smith fracture, and the third one is scaphoid fracture. So starting off with Colles fracture, the main bone will have a volar shift. This is what you have to remember. That's it. And the mechanism of injury is via Fuchs injury, and when the wrist was in extension. So Fuchs is fall on outstretched hand. Then it is also seen commonly in osteoporotic elderly males or females. And then clue to Colles fracture is there would be a dinner fork deformity. It is very significant. You will be able to see the clinical presentation or the X-ray, and you will be able to get to the diagnosis straight away. Now talking about the diagnostic investigation, X-rays is what we are doing for the diagnosis of Colles, Smith, and also scaphoid fracture, which I'll discuss in the video. And with Colles, there would be a distal displacement. Now for the management, it depends on what the patient vitals and status is. So if the patient is stable, then we can opt for a closed reduction and immobilization. And there is a specific direction in which we'll have to apply the cast. It is important, the AMC asks about it. So for closed reduction and this immobilization, the cast which we are applying, it has to be 15-degree ulnar deviation and with a wrist flexion. This is the correct position in which you'll have to apply the cast for Colles fracture. And if the patient is unstable, then open reduction internal fixation or external fixation we can opt for. Now the complications can be median nerve injury, it could be stiffness, or it could be malunion. Next is Smith fracture. So there is a distal radius fracture with volar displacement of the fragment that is fractured. And the mechanism of injury is similar, but in this scenario, it would be a flexed wrist rather than an extended wrist. Now the clue for Smith fracture is you'll be able to see a garden spade deformity. It is diagnostic for Smith fracture. It will be clearly visible as soon as you are checking multiple photos and x-rays for both of these. You'll be able to differentiate between both of them. And talking about the management for it. So management is similar, but the only difference is how you'll apply the cast to the Smith fracture. So cast presentation would be similar. There would be ulnar deviation 10 to 15 degree, but this time the wrist needs to be in extension. And the only option that is being left is surgery if the patient has displaced fracture. So for that we'll do open reduction internal fixation. Now coming to the scaphoid fracture. So there is a specific site where scaphoid fractures is happening. It is also known as anatomical snuff box. And the mechanism of injury is similar to that of Colles and Smith. It is Fuchs. And there would be a radial deviation. For the clinical presentation, the patient will experience tenderness at the anatomical snuff box and there would be pain on wrist extension. So these are the clinical presentations. Now, important thing is investigation. AMC asked about scaphoid and investigation. So starting off with, now for the investigation, there is a high yield tip that in a wrist trauma with anatomical snuff box injury, there would be a normal X-ray and it will take 1 to 2 weeks for the imaging findings to be visible. So we'll have to repeat after initial X-ray in a period of 7 to 10 days so that we can have some sort of finding on imaging, or we can opt for MRI at that time. So after initial X-ray, we'll need to see if the patient is willing to immobilize the arm or if not. So if the patient is not willing to immobilize the arm, then we'll have to do an MRI for this patient. And if the patient agrees to immobilization, then the only option we have is to apply a cast, and we have to repeat X-ray. And this cast will be different from what we have applied in Smith and Coley's. This cast would be in a cup holding fashion, and the thumb would be included in the whole cast. That's the cast for scaphoid fracture. So specific treatment for scaphoid fracture: if the patient is having unstable injury, then open reduction internal fixation is the option that we have. Now if the patient is stable, so we can opt for specific casting and serial X-rays. That's for the treatment of scaphoid fracture. And that wraps up today's rapid fire review. These 5 topics are AMC gold topics, very much asked, high yield topics, and mastering them puts you ahead. Don't forget to like and subscribe and comment down the important topics that you want me to cover, and follow me for more AMC focused and recall backed videos every week. Until next time, keep studying smart, stay confident, and you have to trust the process. You have got this. Thank you.